Good morning, everyone. So today I'll be presenting my poster on the demographic profile and management of branch retinal vein occlusion, that is BRVO. So it is a vascular disorder which emphasizes there is engorgement and dilatation of the retinal veins, basically at the AV crossing sites, that is arteriovenous crossing sites, since the artery is superiorly and they share the common adventitial sheath. The artery can compress the vein and this leads to engorgement, dilatation, and hence further leading to ischemia because of the turbulent flow of the blood, as we know, because of the virtuous triad. So the aim of the study was to study the demographic profile and management of the BRVO cases that were presented to us. This was a cross-sectional study and we took 57 cases. The inclusion criteria were patients having BRVO above the age of 25 years. Since nowadays we are seeing more earlier presentation of the risk factors of BRVO like hypertension, and the patients had to have clear media because we had to take the OCT also to see the macular edema. And the exclusion criteria were any other pathology along with BRVO, any other lenticular opacity which did not allow us to take the OCT of the macula, and a population below 25 years of age. So we basically took history and examination of the patient, which included visual acuity, slit lamp evaluation, IOP measurement, and the fundus examination with 90D and direct and indirect ophthalmoscopy. And we further did the OCT for the macula. Basically, we did the management either medically or with anti-VEGFs, intravitreal or laser. Accordingly, because of the macular edema was present and we thought it needed anti-VEGF, we did anti-VEGF. If it was persistent, we even did laser therapy. So the results were the most common cases that we saw in all the 57 cases. 35 were of superotemporal branch BRVO, followed by inferotemporal branch. The age of presentation were mostly between 46 to 60 years of age, that is 24 cases. Mostly we saw that males had more presentation as compared to females, but the laterality was not, it was unilateral in all the cases. No cases we saw were bilateral BRVO. And the most common presentation were 13 to 24 weeks of the development. Basically, patient even said that they had diminution of vision previously, but they did not report to us. And the most common comorbidity that most of the patient had was hypertension, that is 29 patients. Mostly, the most common management that was given were anti-VEGF because of the macular edema, and most of the cases did not show much, did not show much improvement. Like few worsened, but mostly the presentation visual acuity was almost the same in all the cases. Also, prior to the treatment, 66.6% had central macular thickness more than 400 micron meter, and after anti-VEGF, 88.8% decreased. The macular edema decreased. So to conclude, this was the maximum cases that we found were of superotemporal branch owing to its most number of AV crossings and also the maximum course, and none were inferonasal. Also temporal is most common because the course is longest, so naturally the AV crossing will be more. None were inferonasal in all the 57 cases. The mean age group was 5th to 6th decade. And male preponderance was seen, which could be explained by smoking, like it's a theory. And then no much difference was seen in involvement of the other eye, and all the cases were unilateral. Mostly cases presented later than a month, as BRVO initially does not significantly affect vision. And the commonest comorbid condition was hypertension. The maximum number of patients underwent anti-VEGF, and the maximum patients had the same vision of, that is during presentation and after the management, had almost the same vision. The reduction in central macular thickness also was seen with anti-VEGF therapy.